Published by WordPress.com. Fragility fractures in general trauma. Introduction to fragility fractures. Fragility fractures occur in individuals with decreased bone density or mineralization, typically resulting from minimal or trivial trauma. Osteoporosis is the most common cause of fragility fractures. Common sites of fragility fractures. 1. Vertebral body, common in individuals aged 60 to 70 years. 2. Hip, most common in individuals aged 70 to 80 years. And 3. Wrist, common in individuals aged 50 to 60 years. Bone changes in osteoporosis. Cortical bone, thinner, leading to reduced strength, particularly affecting screw pull-out strength and resistance to torsion and bending. Cancellous bone, less dense with thinner trabeculae and more voids, making it prone to fractures. Fracture healing in osteoporotic bone. Healing time is longer in osteoporotic bones. The callus formed during healing is weaker. Implant failure is more common due to the compromised bone quality. Enhancing fixation in osteoporosis. 1. Medical treatment. Shift toward anabolic drugs, e.g., Forteo, teriparatide, rather than anti-resorptive drugs, e.g., bisphosphonates. Ensure proper soft tissue handling due to aging and associated soft tissue changes, atrophy, ischemia, venous congestion. 2. Spine management. Vertebral compression fractures. Spinal fractures can be managed conservatively or operatively depending on the severity and the patient's condition. 3. Surgical techniques. Indirect functional reduction. Focus on non-anatomical alignment. Locked splinting with long plates or nails, avoiding interfragmentary compression. Use of interlocking intramedullary nails and locked plates for enhanced stability. 4. Bone augmentation. Options include autografts, allografts, bone substitutes, and cement, PMMA, around screws for improved pull-out strength. 5. Joint replacement. Periarticular fractures may require joint replacement, especially in cases of pre-existing arthritis. Biological enhancement using techniques like HA-coated implants, BMPs, mesenchymal stem cells, and gene transfer is being explored. 6. Minimal fixation. In cases of comminuted distal radius fractures, minimal K-wire fixation with spanning external fixation can be considered. And 7. Bone impaction and metaphyseal shortening. Can be used as part of fracture management in osteoporotic bones. Vertebral compression fractures. Vertebral compression fractures are the most common fragility fractures, primarily affecting individuals over 60 years of age. Presentation of vertebral compression fractures. Pain, localized to the area of the fracture. Focal tenderness over the fracture site. Local kyphosis, often seen in patients with multiple compression fractures. Neurological symptoms may include spinal cord injury or nerve root deficits. Imaging for vertebral compression fractures. X-ray. Radiographs of the entire spine should be obtained, as concomitant spine fractures occur in 20% of cases. CT scan. Generally not necessary for diagnosis but may be used for complex cases. MRI. Useful for assessing spinal cord involvement or disc herniation. Differential diagnosis of vertebral compression fractures. Metastatic cancer to the spine. More common in older patients, especially with atypical radiographic findings. Fractures above the thoracic spine, T1, T3, may suggest other causes. Failure to thrive and constitutional symptoms could be suggestive of cancer or other systemic conditions. Treatment of vertebral compression fractures. 1. Conservative treatment, for most patients. Observation. Monitoring for stability. Bracing. Extension orthosis to support the spine. Medical treatment. Manage osteoporosis to prevent further fractures. 2. Operative treatment, for severe cases or failure of conservative treatment. Vertebroplasty. PMMA cement injected directly into the cancellous bone without cavity creation. Increased risk of cement extravasation into the spinal canal. Kyphoplasty. Creation of a cavity with a balloon before PMMA injection. This procedure may also allow for partial reduction of the fracture. Surgical decompression and stabilization, indicated for progressive neurological deficits, posterior ligamentous injuries, or unstable spines. May involve long constructs and combined anterior fixation.